So welcome everyone to this evening's teaching. We again have Simon to take us through ultra-wide retinal imaging. Today, the topic of discussion is on peripheral retinal degenerations. And over to you, Simon. Thank you very much.
Thank you very much again, and welcome all to another session. The only big difference since last time is the evenings are lighter, so isn't that great news? I always used to say, as an optometrist, at this time of year, I used to work in the dark, and go home in the dark. But now we've got lovely sort of light evenings, so that's great. Today's subject, we're talking about peripheral retinal degenerations this evening, and we're not going to be talking about retinal tears, retinal detachments and holes and things. That's all for the May session, and lots of fun and games going to be coming in that session. This one is about peripheral retinal degenerations. That's a slightly different topic. So, of course, we come in June for lots of fun face-to-face conference and lots of good things planned for that. So at the outset, what I'd like you to do, I'm going to ask you a simple question, and I'd like you just to put some sort of a quick short answer, if you would, in the chat, so that when we get to a bit later on in the session, I'm some of the comments there, it'll just interest me. The simple question is, most optometrists nowadays seem to indulge in myopia control, and so the question is, what, if you are undertaking myopia control, what are you looking to achieve with that patient when you undertake myopia control? So what in your thinking are you aiming to achieve for that person? What doing it, and what do you want to achieve? Just see if you can think of some quick answers to that, because obviously you're doing it for some reason. Just want to know what that reason is, and you'll see why I've asked that question as we go through the evening. So, without further ado, peripheral retinal degenerations. Well, with degenerations, we're not talking of sudden things happening. We're talking of often gradual things happening. Obviously, we're looking in the periphery here, and there's lots of different types of retinal degeneration, and we're not going to touch on all of these tonight, or else we'll still be here at midnight. So we're going to look at some of them. Some of them you'll recognize, and we've already talked about in previous sessions, but some of them I want to sort of hone into a little bit more. But as I say, degenerations often have been there for a long time, and they get worse gradually over time. But you can see these fall into very specific categories here. Developmental degeneration, so zonular traction tufts right out in the very periphery. Intraretinal, so senile retinoschisis, white without, dark without pressure. Peripheral cystoid degeneration, which we've mentioned in earlier sessions. Pearl degeneration. And then the vitreoretinal ones: lattice, snowflake, retinal tufts, microcystoid degeneration, pars plana cysts, which again we've talked about before, and peripheral retinal breaks. More of that next month. And then the chorioretinal ones: hypertrophy of the RPE, paving stone and cobblestone, which we're going to spend a bit of time on this evening, myopic choroidal atrophy, reticular degeneration. So there's an awful lot of changes going on out in the periphery. But what do we mean by retinal degeneration? Gradual breakdown of the retinal tissue in those outer regions of the retina. Sometimes these can impact on vision, sometimes they won't impact on vision. They may lead to vision problems, such as reduced peripheral vision or change in vision or loss of vision in the extreme peripheral field. And I think one of the things that we've never really spent a lot of time on as optometrists is actually exploring the change in the peripheral visual field. And at this stage, I'm going to hold my hand up and say there is still a very good place in modern primary care optometry for the confrontation test. Now, here we are dealing with all this wonderful technology, all these wonderful ultra-wide field OCTs, ordinary, everything. And there's still the good, humble confrontation test. And that will tell you an awful lot about what's going on with peripheral retinal degeneration. So don't forget these very simple tests. And the sort of confrontation test where you're bringing something in from the outer periphery and seeing whether you can see it sooner than your patient can see it, so you can compare your visual field with this. It will give you an awful lot of information. So the different types of retinal degeneration, we've got retinal atrophy, and that's the thinning and degeneration of retinal cells. Retinoschisis, well, we've dealt with retinoschisis quite a lot so far. And don't forget with that, that's the splitting of the retinal layers. So we get the absolute visual field loss there, not the sort of the partial visual field loss. Lattice, well, we're going to deal a little bit more detail with lattice degeneration this evening. So a bit more of that later on. Cystoid degeneration and peripheral retinal drusen. Small deposits of waste material underneath the retina. They can impair vision, obviously with macular degeneration, but those peripheral changes can also be highly significant as well. So what causes these retinal degenerations? Well, genetic factors are very sort of prevalent here. Things like inherited conditions, retinitis pigmentosa. Snowflake degeneration is very much a hereditary form. And as we now know from a lot of modern research, degeneration will lead to peripheral degeneration, and also vice versa. Peripheral retinal degeneration can often be a precursor for macular degeneration. Probably the most common cause of retinal degenerations is age. It causes the retina to thin over time and become more susceptible to damage. And of course, trauma and injury, you can never forget that. High myopia. People with severe myopia, much greater risk of retinal degenerations. And then systemic diseases like diabetes, hypertension. These can all affect retinal health. So what about symptoms for peripheral degenerations? Well, quite a lot of the time you will come across patients, if you're doing ultra wide field imaging, you will come across changes in the periphery that the patient has never been aware of. So often these patients will have degeneration and they're completely asymptomatic. And I must admit, I think I might have mentioned this before, there's almost a sort of perverse glee when you see somebody new for the first time and you see lots of degeneration in the periphery. And there's a sort of bit of me that always wants to say, well, of course you knew about that, didn't you? Because somebody must have told you about it before. But the simple fact of the matter is, we do not look routinely far enough out into the periphery. And so an awful lot of peripheral degeneration with conventional ways of viewing the retina goes unseen. But the symptoms that you will get is sort of gradual loss of that sort of far out vision. Often patients will complain of in dim light not seeing as well. They feel as if they're looking through a tunnel during low light, whereas in normal light they seem to be okay. Difficulty seeing in dim light, especially with things like retinitis pigmentosa, of course. Flashes or streaks of light. Now, we're going to deal with those in a lot more detail now, as increased floaters in vision. That, again, has got a lot to do with holes and tears and things. Blurred peripheral vision. Difficulty with tasks requiring peripheral vision. And I think one of the most obvious tasks that if you drill down with people when you question them, if you drill down into them and if they think they've got problems with their peripheral vision, check whether they drive or not. Because the big giveaway is the car. If they're reversing into a space and they're looking over their shoulder to see what's going on, very heavily reliant on peripheral vision there. And you can often glean an awful lot about people's peripheral vision just from the point of view of them trying to park a car. I must admit, sometimes I look at people parking a car and I just assume they've got very poor peripheral vision from what I'm looking at. So it's quite a good question to ask. So diagnosis, well, we're in the game with these lectures of ultra wide field imaging, and as I say, this has opened up a complete new world to us because we can get out into the periphery so much more. Dilated eye exams, yes, they always have their worth. And then ultra wide field OCT has again been an absolute game changer because we can drill down into what's happening in those different retinal layers right out towards the ora serrata now. And as I say, visual field testing, a very, very important component when we're looking at retinal degeneration. So what are we going to do with these when we see the management and treatment? Well, in most cases, I would honestly say mild degeneration, regular monitoring may be all you need to do to track the condition. We shouldn't be referring a lot of peripheral retinal degenerations. We should just be monitoring them for changes and to ensure that no secondary problems arise as a result of those degenerations there. We've got things like laser therapy, laser retinopexy, if and when we need them. Again, surgical interventions we're very much going to look at next month when we're dealing with what to do to try and stick a retina back down. And then we've got things always on the go with gene therapy and stem cell research. So much work going on in those fields at the moment. But I think a very useful everyday thing to work with preventative measures. Now, we've talked about these again in previous lectures in terms of lifestyle, in terms of protecting the eyes, in terms of diet and nutrition. But as I say, preventative measures when you're seeing changes in the periphery can actually be a very, very useful intervention at that stage. The simplest one, if a patient smokes, is to get them to stop smoking. Now, I bring this slide up. It's about this. You're probably going to refer a patient if you've got a retina looking like this, and probably refer them quite urgently. But this is an image that's available. It's a beautiful view on the Optos website. So if you go to optos.com, you'll be able to pick this image up, and there's one for autofluorescence as well. And it's just a really nice, useful thing to do. Look at some of the things with white without pressure, lattice degeneration, retinoschisis in passing as well. So, kind of nice little image there. So let's look at some peripheral retinal degenerations that don't increase the risk of retinal detachment. So we have discussed in the past PRPD or honeycomb chorioretinal degeneration, frequently seen in older people, but remember there is this correlation to vascular disease. People with honeycomb degeneration are far more prone to things like stroke and non-arteritic ischemic optic neuropathy. And so be aware of that. Somebody did actually send me an email after last month's lecture asking me when they see honeycomb degeneration, should they be referring it? And as I was saying to them in response, it's very much taking the holistic view with a degeneration like this. We're going to see age-related degenerations, but it's looking at the other factors. It's looking to see, are there any signs of vascular problems there? Do the muscles look any different? Are the crossings abnormal? Is the patient on medication? Does the patient smoke? So take the fuller picture when you see honeycomb degeneration and compare that, and then look at the patient in a more sort of holistic way if you're going to make a referral. I still say that there is absolutely nothing wrong if in primary care you are taking blood pressure readings on a patient and also taking carotid sound tests as well on a patient. There's nothing wrong with that, and it also helps you provide a much more thorough referral back to the patient's general practitioner and primary healthcare team in the GP practice. So yes, do bear that in mind. Peripheral drusen, again, as people get older, we're going to see more and more drusen. Drusen, what are they? Well, multiple, small, focal, yellow lesions, often found around the equator and outwards, right out to the ora serrata, the periphery there. These are well demarcated. They can present with pigmented borders. You'll normally see this in both eyes, and again, you will see it accompanying the honeycomb degeneration as well. and there is absolutely no doubt they will increase in prevalence with age. You've got hard drusen, you've got soft drusen, and these are the two subtypes. And fluorescence, they will be either hyper or hypofluorescent, just to make your life difficult. But as I've said in the past, the crystalloid ones tend to be hypofluorescent, whereas the lipoidal ones will be hyperfluorescent. And this is the classic sort of honeycomb degeneration, the change in pigment in the periphery here, which when you look at the surface of the retina tends to look mottled, but when you look at the red channel down at the RPE level, you can see this sort of very sort of specific shapes, the polygonal shapes of the pigment agglomerations here. And so this is the sort of thing to look for. And then on all classic lace-like pattern to the periphery there. Just do remember this vascular anomaly.
Sorry, Simon, can I just interrupt? Could you just repeat that last sentence because we did miss it?
About the autofluorescence.
Yes, please. Yes.
Yeah. So with autofluorescence, you get this classic lace-like pattern in the periphery here. And this tends very much to agree with the areas of pigment degeneration as well. So unlike the change with retinitis pigmentosa, where you'll get a sort of penumbra of bright hyperfluorescence, you get this very classic lace-like pattern just here. But remember the association back to the vascular changes, as I said, it is important. And, you know, blood pressure checks, carotid Doppler analysis. These carotid Doppler machines are very, very common in a GP practice with the diabetic nurses. They will quite often use these to listen to the blood flow in a diabetic patient's legs. And it's exactly the same thing you can use in practice. They're not expensive and they're really useful. And if you're getting a suspicious reading, it really does help the GP to have that information when you're referring. And remember, if the patient's smoking, give advice on stopping smoking and direct them to your local smoking cessation or stop smoking services as well. So drusen, they come in all sorts of shapes and sizes. Small, tend to be small, yellowish deposits. They collect between the retinal pigment epithelium and Bruch's membrane. And that's important looking at the site of them there. They're primarily made of lipids and proteins, and they occur naturally. You could almost call them the wrinkles of the retina if you really want to. They occur naturally with age. And usually, if you remember from what I've said before, usually the retinal pigment epithelium will be breaking down waste products and through phagocytosis and ejecting the waste from the retinal pigment epithelial cells. But if that clearance pathway becomes overwhelmed and damaged through oxidation, the debris can accumulate and will then break down further into drusen. So drusen are a sign of interrupted normal metabolic function, and that's going to increase with age. They're categorized by their size. So small drusen are under 63 micrometers, intermediate 63 to 125, and then large drusen as well. And then, as I said, down into hard and soft drusen. Hard drusen are small, very well defined edges. They look very, very sort of discrete in their appearance, as opposed to soft drusen that are much more amorphous in their appearance. They're much larger, indistinct edges, and they will often merge to sort of create these large drusen plaques that you see in the periphery. And if you're seeing intermediate or large drusen, this is telling you this is a major risk factor for vision loss going forward. And don't forget also, if you're seeing plaqued drusen in the extreme periphery of the retina there, this has been shown to correlate very, very much with amyloids plaquing within the brain. And this association with Alzheimer's and dementia is very, very well established now. So I'm not going to go into the sort of medico-legal route of diagnosing early, previously undiagnosed dementia and Alzheimer's. But I said, just come out for 10 years ago now, that within 10 years, our profession would be right at the forefront of diagnosing this in routine practice. Maybe I was being a bit optimistic there, but I certainly think given another 5 years and with the inclusion of AI as well, I really think within the next 5 years, with the progress that's being made, we may well be in the forefront of looking at these peripheral degenerations and looking at early Alzheimer's changes in people. Very, very exciting, I have to say. We have reticular pseudodrusen. These are subretinal drusenoid deposits. So you remember at the top there, I said about how standard drusen appears between the RPE and Brooks membrane. Well, reticular drusen is different depth there. These form above the RPE layer, unlike typical drusen. And when you start seeing reticular pseudodrusen, their presence is very, very strongly linked to late stage AMD and associated vision loss. So these people, they may have nothing wrong at the moment, but they're going down a path that is possibly quite a bad path to go down. So again, always differentiate between normal drusen and reticular pseudodrusen because they're going to tell you a different story. Now, I do not intend to go through this table here tonight. You'll probably be very, very pleased to hear. But this is obviously there for you to go back and look at in the recording. This is a lovely table from a paper produced by Carm et al. Back in 2016. And it very nicely breaks down the different types of drusen, what they're going to look like with color fundus photography, what they're going to look like with autofluorescent OCT, and fluorescein angiography and indocyanine green angiography as well. So this is quite a nice little sort of aid memoir to have within the consulting room when you're looking at drusen as well. So I'll say no more on that, but do go back and refer to that because there's a lot of information in that there. So this is the sort of thing that we're going to see here when we're looking at drusen. These are these classic very well-defined spots, pigmented around their edges, very much in the nasal periphery. You see a few more scattered around here as well. And then when we look in the other eye, they're very, very normally binocular. And so you'll see exactly the same sort of pattern in the other eye. These are not going to affect vision, but they're classic signs of aging and of a retina that has been under stress. And so this is where I commented about the gradual degeneration that you'll see over time. This is again the sort of retina you'll see in an older person. There's a lot of sort of telltale giveaway signs here. This is soft drusen, far more amorphous in its appearance, and you can see how these coalesce to begin to form these much larger plaques out in the periphery. But you'll also see scattered other drusen. There are giveaways in this image that this is an older patient. So the main giveaway, if you look carefully in the center here, you see these two little circle artifacts here. They are front and back reflections off an implant lens following cataract surgery. So this is an older patient. This is a classic sort of change you'd expect to see in a patient. You're not going to refer this sort of thing. I used to say to my patients, I would almost worry if I didn't see that in somebody in your age group. But it gives you at this point in time the chance to intervene with these patients and look at their lifestyle and any modifications that are likely to help them. Peripheral cystoid degeneration, we've dealt with that in previous lectures. I put it back in here, as I say, so that you can come back to these. These are sort of yellowish vesicular-like lesions, but they're within a hazy grey area of thickened retina. So if you're not sure whether you're looking at drusen, look at the area around it, and if you're seeing this sort of hazy greyish area, then this is probably cystoid degeneration you're looking at. And again, these will coalesce over time as well and can lead to development of acquired retinoschisis as well. And then chorioretinal atrophy, paving stone or cobblestone degeneration. And we've all seen these. We talk about window defects, and really the definition of whether it's cobblestone or paving stone purely in size thing, really. These are well circumscribed circular areas of retinal thinning, and it's a loss of the retinal pigment epithelium and the photoreceptors inside those. And they just drop out, very much like geographic atrophy in the macula. So you can see the underlying choroid layer much, much more clearly, and you'll see the choroidal vasculature more clearly. You will see pigment cut around the edge, and as I say, these can coalesce to form quite large window defects. If you look with the OCT, if you can get out wide enough, you'll see a loss of the RPE, you'll see thinning of the outer retinal layers. And again, you can almost call it geographic atrophy elsewhere, for want of a better way of putting it. And the autofluorescence will invariably show hypofluorescent areas because there is no lipofuscin production within those areas because it is out. But don't be fooled. You can sometimes see it looking brighter, and that's purely and simply because where it's much thinner, you're getting show through of the sclera underneath that, and that can sometimes make it look bright. But in the main, you tend to see it looking hypofluorescent, and unsurprisingly, more prevalent with increasing age. Both of these, it's just routine review of the patient required. We're not going to refer things like that. Just drilling down a bit more into these degenerations, these are characterized normally by discrete areas of atrophy of the outer retina. They do occur singly. As you can see, they're present in up to 30% of the general population, and 33% of those are bilateral, but are going to increase with age as well. So look for the large choroidal vessels underneath through the RPE. And the lesions are most common in inferior quadrants. Again, you quite often see these comments made. Certainly what we do find now is with ultra-wide field imaging, because we can generally look much wider, you will actually see them around lots of areas of the retina. And this is classic cobblestone and paving stone degeneration here. Again, you see the geographic atrophy, and you can see why we call it geographic atrophy elsewhere, because it's the same sort of appearance in many ways, and you see the much clearer choroidal vessels showing through these windows here. Here's some cobblestones, and here's some paving stones, and you can see how, again, these are beginning to coalesce even at this stage. And this is a very common sort of thing you'll see in an older style retina. You've got drusen in the periphery, you've got cobblestones, you've got paving stones, and you've got very large areas of paving stone degeneration here. And you've even, to boot, got a retinoschisis in there, which has been an acquired retinoschisis as a result of degeneration. Again, with all of this, it might look quite spectacular, but in actual fact, we're going to monitor that patient. You may change your mind when you look at the geographic atrophy here, but this is looking like a dry patient, so it's a monitor. And another classic sort of degeneration here, you can be fooled sometimes into thinking these look like retinal tears, but in actual fact, that is just paving stone degeneration, and here is very commonly mixed in with this, the pigment that you see there as well. So these are all forms of paving stone or cobblestone degeneration due to loss of the retinal pigment epithelium. We're going to monitor these. That's all we want to do with those. Now, retinoschisis, we've covered retinoschisis in previous lectures, but just a quick little revision here. We're looking at these sort of blisters, if you like, on the retina. We'll look for the white surface dots, the guns dots over the top of them. You will see them there. And remember, this is a splitting of the retina. It's not a retinal detachment. So the retina is still firmly attached to the retinal pigment epithelium underneath. It's the actual layers of the retina that are splitting apart. And this is why you will get an absolute scotoma with these particular lesions. They are invariably asymptomatic unless they begin to encroach further towards the macula. And so therefore, we just really need annual review on these. But if you are beginning to see changes in size and they are beginning to encroach on the macula, then you could consider a referral at that point. and again, called degenerations, it's exactly the same thing I'm doing with
Oh,
that.
oh, sorry, Simon. We lost that entire sentence
Uh,
after refer.
Okay, so degenerative retinoschisis, very much the same sort of thing as the flat typical and the bullous reticular type. It's really a case of just monitoring, but if the patient is becoming symptomatic, uh, you may want to refer to a vitreoretinal specialist for a second opinion, just to make sure. And I think the thing to look for here is whether you've got holes opening up in the top and bottom surfaces of the retina where the schisis is, because if you've got vitreous liquefaction there, then you're opening up holes for the vitreous to work its way through, and therefore it can detach the retina underneath. So if you're seeing any signs of progression, then very sensible route to take the safe route and get a vitreoretinal opinion on that. One thing, if you really fancy doing a bit of scleral indentation, then you can tell the difference between a retinoschisis and a detachment in that the retinoschisis will remain elevated as opposed to a detachment, which will flatten against the indentation. But I strongly suspect I'm not going to see you all running out and trying scleral indentation to do. Uh, it's far better to do a peripheral visual field test. But seeing this image before, I bring it up again at this stage. You get this very classic, uniform, convex edge to the lesion, the darkening of the vessels as it comes over this bullous shape. Think of a blister on the end of your finger and filled with fluid. That's what this is. It's kind of what you're looking at here. And these are the typical white dots you'll see, guns dots over the top. And remember, when you look at this in autofluorescence, it will appear dark. The reason it appears dark is not because the retina it's detaching, it's because there is a very viscous fluid within the retinoschisis, and that is what's blocking the signal, if you like. So the retina remains firmly attached. The retinal pigment epithelium is still functioning normally underneath all of that. So again, these were ones that could increase the risk of retinal detachment here, and with schisis detachment is where you've got the holes in that, so you need to look for those. Vitreoretinal tufts we've dealt with in previous lectures as well. I just bring those up really because again, these are little thin projections of abnormal glial tissue, typically found right out in the far periphery. They don't tend to lead to formations of retinal holes or tears, but again, when you've got vitreoretinal traction going on, then these extra areas of heavy attachment can sometimes cause tears there. So PVD will, at the time of PVD, cause increased traction on the tuft, so you could get a tear from there. But in the main, generally, annual review is what's required. One of the things to look at with the schisis detachment is if you're getting a pigmented demarcation line around that area, this can often show a sign of a collapsed schisis, which has detached but has effectively sealed itself. And that pigmented line suggests it's been pretty stable for at least 3 months. And so it's probably not going to cause a problem to you. And this is what this image shows here. You've got a collapsed old schisis here with this pigmentary line here. Now, you could be a bit gung-ho with these patients and say, well, that's probably okay. I must admit, I think with a patient like this, it is sensible to get the opinion of your local vitreoretinal specialist and say, in my opinion, this looks like a collapsed schisis that is a stable, resealed retina, but I would value your opinion of it. And I think that's a perfectly sensible thing to do at that point in time. So if you think that it may have reattached, but you're not sure, refer every time just to get that valued opinion. And then these tufts, it looks like it's a retinal tear. It's actually not. It's just a tuft, and you can see on the OCT just how this is pulling up and being pulled into the vitreous there. So again, ultra wide field OCT, a very, very useful thing there. And this is one of my favourite tufts of all time. You can see an area of white without pressure here, and you can see here this tuft. Now, the way I liken this is if you were to get a piece of cling film, wet it, and put it on a kitchen surface, and then pull up in the middle of that cling film, you'll get a tuft coming up in between your fingers, and it'll seal around the kitchen surface quite tight, and you'll end up pulling quite forcefully after a little while. And that's exactly what's going on here. If we magnify this up, you can see how the vitreous is obscuring the retinal blood vessel here, and this is pulling up into a peak. Beautifully shown on the green channel there. And the reason I so love this tuft is it belongs to my daughter. And my daughter was 16 when this was taken, and she was nearly 17. She was just due to go off to Australia for the best part of a year, and this was 2 days before she flew. She popped in and I saw this. Downloaded it onto her phone and said, look, if you have any problems or symptoms while you're out there, then do take this image along with you. And she started getting some floaters. She went to see an optometrist out there. This was before Australia had Optomap. And I got a very, very nice email back from the optometrist out there saying, how on earth did you manage to get an image like this? I'm pleased to say that Australia now has Optomap, and it's been beautifully embraced out there. So again, peripheral degenerations like this can show up really nicely. Zonia traction tufts, these are make an appearance very early on in life, and they are very difficult to see, but they are right out with an association to the zonules of the lens. So they're generally stable. They don't change over time. I've put it in tonight as a peripheral retinal degeneration because they are, and they're there. But even with ultra wide field imaging, you probably won't see a lot of these at all. But this is why it's important when you take an image to really do that first analysis of it, just to see if there's anything going on in the extreme periphery there. Now, snowflake degeneration is quite an interesting one, really, because people tend to use the term snowflake degeneration when it's not true snowflake. But this is actually a genetic disorder as well. Very can be used with Wagner's or Wagner's syndrome, but Wagner's syndrome shows very specific changes that you don't see with snowflake degeneration. But these white dots are minute yellowy white crystalline deposits, much more common in the peripheral retina. Many patients will have early onset cataracts to go with them, and they'll have corneal changes as well. So again, look for those, and look for the genetic associations there as well. You will probably find other members of the family have reported the same thing as well. And if you've got patients with snowflake, then obviously look at their descendants as well, because there's a good chance that you'll see that in them. And many of these patients will experience symptoms of floaters. And these are not brilliant images, I'm afraid, but these are the sort of images that you will see with snowflake degeneration. Now, lattice degeneration. Oval, linear bands, thin retina. It's something we're very familiar with when we see it, but we do miss it a lot of the time. Characteristically, it's orientated parallel to the ora serrata. So if you've got something that's coming in like the spokes of a wheel on the retina, it's not lattice degeneration. Lattice will go around the periphery. And the OCT is very useful here because you'll see retinal thinning and often see overlying vitreous liquefaction as well. So there is a very strong association with retinal tears and retinal detachments. So you need to review these patients regularly. You need to make the patients aware of this degeneration so that they can look for symptoms as well. If you do see an increase in size or other signs of progression, then referral is warranted if you're not sure. But if you begin to see tears, it's not warranted it's indicated and it's urgent if you've got tears there. And I throw in with lattice degeneration, snail track degeneration, because snail track is now recognised as a variant of lattice degeneration. Looks different because the reason it's called snail track, it looks as if a snail has crawled across the surface of the retina. If you look outside your back door of a morning and you see that sort of silvery snail track left across a paving, that's how it's on the retina. Often you'll see atrophic holes within there, and you'll remember we've said in the past atrophic holes are not a problem. So just manage that as you would lattice degeneration. Now, I'm going to interrupt lattice degeneration at this stage to look at the whole thing of myopia and peripheral retinal degenerations. And I just want to look at the chat at this stage and just see what anybody has put in here. So I'm very pleased. We've got slowing down myopia progression and potentially reducing risk of developing diseases such as glaucoma. Yes, this is good. And the most important one, and that's been picked up by 3 of you, is reducing or controlling axial length in myopia. And that's the main reason for controlling myopia. To put it bluntly, with myopia, if somebody's -4, -6, -11, we can control the refraction by various means of either high index lenses or contact lenses or surgery. That we can do. But the increase in the axial length is what will cause the peripheral degenerations. So if you are dealing with myopia control, the reason you're doing myopia control, in my opinion, is all about axial length, controlling axial length and keeping that axial length to a minimum. So thank you for that. Those are really important there. And I want to spend a bit of time because I think in our everyday life in practice, myopia is going to be the one that we mainly deal with when it comes to peripheral degenerations. And when you look at some of the figures, a great paper written by Nicole Poon, an optometrist in America. Some of the things that she brings out in this paper, the global prevalence of myopia is projected to reach 50% within the next 25 years. Massive amount of myopia. And 10% of those people are going to have high myopia. And with high myopia comes the risk of pathological complications. Myopic macular degeneration, from our point of view, retinal detachment. When we're looking at the peripheries, retinal detachment, cataracts and glaucoma. And then traditionally, when I was at university, I think as I said to you before, we did have electricity in those days, but when we were there, myopia was all about refraction and getting the patient to see as well. And you'd see little Johnny, he'd be sort of 10 years old and he'd be -1, and then you'd see him a year later, he'd be -2. And our attitude with the parent was, well, probably with this growth, little Johnny's going to end up at -7, -8. And that's really as far as we went with myopia in those days. And it was all about the prescription, the amount of minus. Whereas nowadays there is this paradigm shift towards incorporating axial length measurements. It's all about axial length. And this has become the new standard of care within optometry. And when we're looking at myopia management, we should be looking at the axial length of the eye in as bigger essential way as we would be looking at visual fields and OCT when we're looking at glaucoma patients. So when we look at pathological myopia, we see structural changes, and we're looking at an axial length that's greater than 26 millimeters. So the goal of what we're trying to achieve with myopia control is to keep that axial length under 26 millimeters. And when you look at what the statistics show you here, an axial length greater than 26 millimeters, there's a 25% chance of visual impairment. But that increases to 90% if the axial length is 30. So a huge increase once we get beyond 26 millimeters. And more practices are beginning to use biometry as a routine measure in practice. And if you're not at the moment, I would certainly encourage you to have a look at introducing biometry, because some of the software nowadays actually incorporated will allow you to track progression and prognosis for a patient when you're doing that. And I was just saying before the lecture tonight, I've actually just received an invite to a conference in America on myopia, and the vast majority of that conference is actually about axial length. It's not about prescription. And I think that shows the importance of that. So what types of myopia do we have? Well, we have the standard definition of myopia. Then we have axial myopia and refractive myopia. But axial is the one that we're dealing with specifically with peripheral retinal degenerations. Quantitatively, myopia, anything from -5 to -6 is what we call low, minus a half, sorry, -0.5 to -6, we call low myopia. High myopia over -6. So, and I just wanted to show you at this stage a couple of studies. This was a study carried out in North India, and this was looking at the type of peripheral changes in a myopic population. And you can see here the sort of things we're dealing with. Peripheral retinal degenerations found in just over half of all myopes in the study. The most common peripheral degenerations were lattice and white without pressure and chorioretinal atrophy. Most retinal degenerations are in the temporal quadrant, and there was a significant positive association between the prevalence of peripheral retinal degeneration with age and axial length. So again, there's a study showing everything we've got there. This was going back to Australia again, and again, I'm not going to go into it in a lot of details, but just look at the changes here. The overall prevalence was 8.5, 8.1%. A longer axial length was a more significant factor in increasing the risk of PRD. And the likelihood of PRD, 50% at 26.9 millimeters, 95% at 29.6 millimeters. So this is information that is crucial to us, and as it says here, it should be something we're bearing in mind with our patients all the time, because we should be able to pick out our patients who are at risk, and we should be screening those patients regularly for peripheral changes and increased risk of retinal detachment. This was a paper put out in June 25 last year at the ARVO conference, and this is an ongoing study here. And again, you can see 76% of patients within the study had at least one retinal finding. 32% had a vitreous or peripheral retinal finding with the potential to increase the risk of sight-threatening complications. So again, practitioners should perform an annual dilated retinal exam. Well, we don't need to do imaging of the patient there. So again, axial length is so important. Another study here, and just look at a myopia population against an emmetropic population. Peripheral degeneration seen in 38% of the myopes, 6% of the non-myopes, the emmetropes. So important to understand that peripheral degenerations will come with myopia. And then pathologic myopia, you've got excessive axial elongation associated with the myopia, and with that comes a whole series of problems: staphyloma, maculopathy, optic neuropathy, and a whole range of lattice, white without, pigmentary degeneration, paving stone. This is all because we're stretching that retina. If you take a piece of plastic sheet and pull it and pull it and pull it, eventually, if you keep it under stress, you will see little holes come in that as it breaks down because of the stress. This is what's happening with the retina at this stage. And we see here some classics. This is an 83-year-old. You might say, well, this is an 83-year-old, that's old. It's not, I promise you. But Basically, these degenerations are gradual over time. So they build and build and build. So we want to sort of try and prevent these building. But you see this drusen-like deposits in the sort of out towards the periphery here, staphyloma in the centre there. 69-year-old, 26 millimeters, and you've got drusen-like deposits in the periphery. And again, here, 69-year-old, 30 millimeters. You see much more peripheral degeneration in that myope with the long axial length. Now, although we're dealing with peripheral degenerations tonight, I thought I'd just mention staphyloma as well, because it is a part of high myopia. And so you're beginning to see breakdown of the sclera and the bulging out of the eye in those places. And I think the important thing when you're looking for staphyloma, 1.4% in eyes having an axial length of 26.5 to 27, 72% in 33 to 36 millimeters. So again, if you've got high myopes with long axial length, much higher than staphyloma. But this is why it's important to know what that axial length is at the same time. So these are classic views of staphyloma here. As you can see, these aren't peripheral degenerations, but we lump them in the whole myope thing. So let's go back to lattice because of the association with myopia. So the characteristic features include localized round, oval or linear areas of retinal thinning, pigmentation, glistening surface flecks, round, oval or linear white patches, round, oval or linear red craters, small atrophic round holes, branching white lines corresponding to the retinal vessels, and these have thick or hyalinized walls. Sometimes you'll see little tractional tears at the posterior margin of the lesion, and you'll see varying amounts of pigment. But the important thing I want to put here, we always talk about lattice degeneration having white lines across it. Whites do not have to be present in lattice degeneration for it to be lattice degeneration. And so just because the white lines are crisscrossing it may be absent, it doesn't mean it's not lattice. And we have another study here, and just again look at the increase in the amount of myopia, the amount of lattice degeneration when you've got myopia there. So 26% found to have lattice degeneration, 57.7% seen in the 20 to 40 year age group. So again, it's a degenerative thing that's going to increase over time. So prevalence of lattice was higher among patients with high myopia and high axial length. So when you're seeing patients with myopia, we should always have a really raised suspicion that this patient will have lattice. Even if they've got low myopia, these patients will, I won't say you should assume they've got it until proven otherwise, but that's not a bad route to go. So you've got a myope, you must be looking in the periphery for that lattice degeneration. And these are some of the sort of images. I could show you thousands of these and they'll all look different, but you can see the sort of characteristic view, lots of pigment. Here are your white lines, but you've got white areas, you've got pigmented areas, you've got little breaks, and you can see with that quite characteristic, these are some taken with Optimat. You've got the pigmentary degenerations, and you've got the little white lines. Absolutely classic. And that's looking at the surface there. That's looking at the base. It's not a very good image looking at the red channel in this one. But again, areas of degeneration here, areas of pigmentation, all circumferential in its appearance. It's not coming in this way, it's going around with the ora serrata. Always magnify these up. Always magnify them to have a very good look in there to see if there's any small peripheral changes in there. And you then get these long bands of degeneration. Again, magnifying them gives you so much more information as to what's going on. And another classic one here with a bit of folded vitreous here. And all of these are classic. Now, snail track degeneration, as I said, is a form of lattice degeneration, but you can see the difference in its appearance. It's like this snail track here is dragged up it. And you'll see next to this, I've got a book by Richard Spade and his colleagues on pathological myopia. If you really want to understand pathological myopia and the changes in the periphery, please do go and get this book. You can get it electronically or you can get it physically. It's a brilliant, brilliant book and some fantastic chapters written by some very, very good people. You'll learn an awful lot about pathological myopia, and I do strongly recommend that to you. So again, classic snail track across the retina. If you look at the surface, you can see the snail tracking. If you look at the red channel deeper down, you can see how the choroidal vessels appear clearer here because the retina is thinned. And that's one of the characteristics. And then you see multiple snail tracking around the periphery here. This patient's got a very high risk of retinal tear or retinal detachment at the point of PVD. So really important to understand these peripheral degenerations. And here we see a bit of white without pressure, a bit of dark without pressure with associated snail tracking there. And I've chosen to put that one in there because we'll just have a quick little look towards the end here at white without pressure. It's a common condition, very, very common. You'll see it in so many people. Again, as people get older, it's a degeneration that increases with age. It can be flat or slightly elevated. It will can cover diffusely the whole of the retinal periphery. You can have little white dots on it. And again, your myopes with increased axial length are going to develop it much, much sooner. And as I've said in previous lectures, I could show you 1,000,001 of these. They all different shapes. And the important thing is to look at the red channel to ensure there's no fluid underneath there. We can see the choroidal vessels. So that's all looking nice and clear. But again, instead of just this diffuse around the edges, you'll often get these sort of discrete areas. And again, go back to the cling film on the kitchen surface. You see the sort of the margin around the white without pressure, where you've got the margin of traction going on there. This area here is actually called dark without pressure as well. So again, a very large area of white without pressure, but the margin or tide mark, as I've referred to it in the past, of dark without pressure. Now, dark without pressure is a bit of a funny thing because it's not really well understood. It was actually only first described in 1975, but you just see these large areas of flat, dark lesions. They're can be small or they can be really quite large. They've got well delineated margins. Some are very regular in shape, some are very irregular in shape. But the characteristic of these is that there's nothing we can really do with them. We don't know what they are, what's causing them. But if you follow these patients up, that dark without pressure will often change in shape and size and may actually disappear completely. So we're just going to review dark without pressure. It's not going to affect the vision. But the one thing that was very interesting was during the days of the Ebola virus, there was found to be a very strong association with those that managed to survive the Ebola virus and dark without pressure. And in fact, Optos actually sent some of their devices out there to monitor the patients. But this is classic dark without pressure. Just these large sort of flat dark areas anywhere in the retina, and autofluorescence will show them up as dark as well. And again, you've got white without pressure, but with this dark without pressure as a sort of an atypical form of dark without pressure. Nothing to do with them, just monitor them and don't be surprised if they're not there the next time you see them. And here is one of the images taken from an Ebola patient who's showing quite a few changes in Ebola. If you remember the Ebola virus, if you survived the Ebola virus, you were very lucky at that stage anyway. So that's just quite an interesting one to finish on. So lots of references to tonight's lecture and lots of things there for you to go away and read as well. It's there's so much goes on in the periphery, but I wanted to major a lot on myopia tonight because so many of these degenerations you will see will be associated to your growing population of myopic patients as well. So do help yourself to those as well. So thank you very much again.
Thank you. As usual, you were brilliant and I've learnt a lot. There are a few questions in the chat. Is it okay if I pose them now?
Yeah, please do. Yeah.
Brilliant. So I'll just start with the first one if I can. So the first question, I think you answered this actually, to be fair. How do you differentiate between schisis and a serous detachment? You
Go
have
for a
answered
visual field plot. The visual field plot will always tell you because the schisis is an actual slit within the retina. A serous detachment, the retina is detached. So you'll get a partial scotoma, whereas the schisis will give you an absolute scotoma. So in the area of the schisis, absolutely no visual field at all, and a very sort of immediate border at the edge of it. So you go back to full sensitivity, no sensitivity. And you can always plot the schisis on your visual field plot. It's that accurate.
Amazing. Thank you. And then the next question is, oh, this is a controversial question, I think. Do you think we should be measuring axial length in myopic children, slash those at risk, i.e. monitoring? And how would you best measure axial length in practice?
If you'd asked me that question 2 years ago, I'd have probably said, well, if you want to. But the whole of the world of optometry is veering towards a categoric yes, because axial length is the new kid on the block when it comes to myopia. And myopia control is about controlling the axial length of that patient. And as I say, if you go into this in more depth, you'll see that you've now got some fairly strong predictors out there of what's going to happen to the axial length of an eye if you treat it, how you treat it, or if you don't treat it. So the feeling more and more is yes, we should, and that's why I said in the lecture that you won't go far wrong if you begin to look at your next piece of kit after you've bought your ultra wide field imaging device. Of course, your next piece of kit should probably be a biometer. And have a look at what's out there and also the software programs that go with it as well, because very, very much axial length is the name of the game. And if you're practicing myopia control but you don't know what the axial length of that patient is, then what you're really doing is saying, am I controlling the refractive error? Because that's the only thing you've got to go on. And if I suppose a good way of looking at this is if you flattened the cornea. So if you've got a patient who's -4 and you flatten the cornea, so it comes back to -2, but the next time you see him it's -4. Is it because if the cornea is flatter, it must be because the eye has got longer? So if you see somebody who's -2 and there's now -6. Okay, you can measure the corneal curvature, and if it's got steeper, hey ho, there's an answer. But if the corneal curvature is the same, then the eyeball must have got longer. As I always used to say, you pull the screen further away from the projector.
Yeah.
But in pulling the screen further away from the projector, you have put untold stress onto the eyeball with that elongation. And you do not know what length it is. You don't know what length it was to start with, and therefore what it's gone to. So I would honestly say that don't go out and buy one tomorrow. Wait for the sales. But, it's certainly a serious piece of equipment we should be looking at putting in our practices now.
Yeah. Yeah. I concur. So, oh dear. We are
Maybe,
off, definitely not on sales in this teaching.
maybe we should find a biometer sponsor for June.
Yeah, absolutely. Um, I'm just going to stop the recording. Thank you so much, by the way.
Pleasure.